Hey everybody, and welcome back to another video here at Whiteboard Doctor. We appreciate you checking it out. Today, interesting topic. It's going to be under our ventilator desynchrony kind of set of videos, but there's a little more to it in this one. And that's the topic of auto PEEP, also known as intrinsic PEEP, also known as breath stacking, also known as air trapping, would all be different verbiage for the same concept here. So that's what we're going to dive into today. For those new to the channel, we appreciate you checking us out. If you have more interest in videos like this, we have a full pulmonology playlist here with a number of different videos on different topics, including ventilator mechanics. We've done some intro to ventilator waveform and scalars, ventilator desynchrony flow starvation, another video on double triggering premature cycling, and some of that. So we'll link all that in this video's description if you have an interest, and we'd love for you to subscribe, stick around, check out some videos, and leave some comments. So with no further ado, 30-second break for the introduction, then we'll dive in. Hello everyone, and welcome to another video here at Whiteboard Doctor. Thanks for joining us today. Here at Whiteboard Doctor, our mission is to provide you with free, interesting, relevant, understandable medical education and news for all types of lifelong learners, trainees, and practitioners. We have weekly videos that we debut Fridays at 5 p.m. Eastern Time with bonus medical education videos posted throughout the week. We'd love for you to join the Whiteboard Doctor community and follow along by hitting the subscribe button located in the bottom right-hand corner. We also encourage all likes and comments, even if it is just to say hello. All our video descriptions contain links for additional related videos that might be interesting, so don't forget to check those out. And lastly, a quick disclaimer, none of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on. With no further ado, stay well, keep learning, and let's get to the video. All right, thanks for sticking around. So to get started, auto PEEP or intrinsic PEEP or breath stacking or air trapping, I should say PEEP with the little I after it, stands for intrinsic PEEP. I for intrinsic and then PEEP. What is it? So these are the scalars here, and we're going to come back to this because it's nice to demonstrate a lot of these things on these scalars. But to get into some of the introductory knowledge, what is auto PEEP or breath stacking or intrinsic PEEP? Well, it in general occurs when a patient does not have enough time to fully expire before another breath is delivered. And this is primarily a concept that occurs when a patient is intubated or on a ventilator, right? Because we set a lot of what that patient is going to experience, how fast they have to breathe, how much volume or their tidal volume that they have to take with each breath, how much time they have to inspire and expire. All these things are things we can set on the ventilator. So this is often a self-inflicted wound that usually is secondary to some kind of underlying disease state or illness that the patient has, often probably the reason they ended up on the ventilator in the first place. And what happens when the patient does not have enough time to fully expire their full breath, aka the ventilator gives them a breath in, and then they're blowing out that breath, they're expiring that breath, but before they're done expiring that full breath, the ventilator delivers them another breath. So what happens, if you can picture it, is that this leads to an amount of retained volume in the lungs that builds up over time. And that volume building up over time is what causes the auto PEEP or the intrinsic PEEP or the breath stacking or the air trapping. Again, four terms all for the same concept. So to try to understand this a little bit better, I drew out a really crummy diagram of the trachea, airways, and lungs and labeled them conveniently. So this is the trachea here, the windpipe. It goes into smaller and smaller, bronchi, bronchioles, and eventually into the terminal branch alveoli. So this is a very small airway, and then this is kind of the air sac, the alveoli at the end where gas exchange occurs. And what we see with a breath being delivered by a ventilator, I didn't actually mean to delete these other little airways here, so we'll just draw those back in. But what we see with a breath being delivered by a ventilator is essentially, and there's some variability to this, right? There's volume control ventilation, where we set the amount of volume the patient gets. There's pressure control ventilation, where we set the amount of pressure a patient gets. For the sake of ease, all these concepts we're talking about, we're going to assume the patient is on a volume control mode of ventilation, where we set the amount of volume they're getting. And what that means is, let's just say we set the tidal volume, all right, TV for tidal volume, at 400 cc's or 400 milliliters of air. What that means in a simplified form is that every breath, the ventilator is going to deliver 400 cc's of air, and that air is going to distribute into the large airways, the smaller airways, all the way down to the incredibly large number of alveoli in the lungs. And it's going to distribute throughout all those spaces that are exchanging air. And what happens then is the lungs inflate, right? So these lungs are going to inflate outwards as the ventilator pushes in those 400 cc's of air. When it's done pushing that in, the patient then breathes out. They expire. And what happens in a normal physiology of the lungs or a ventilator that's well set up is when the patient expires, right, these lungs move inward and they push all the air back out, and that air travels up the alveoli into the small airways, into the large areas, into the trachea or windpipe, and then out of the patient. And in a perfect world, the amount of air expired is equal to the amount of air inspired. So there's a little different kind of verbiage on the ventilator itself, but for the sake of ease of concepts, we'll say tidal volume inspired with a little I, and then tidal volume expired with a little E. And again, in a perfect world, these things equal each other. The amount of air inspired is the amount of air expired. But what happens when the lungs are diseased, right? Let's say that there's a bunch of disease in the lungs, and those lungs can't expire at a pace fast enough to empty all that volume before the ventilator says, oh, it's time to give you another breath, right? Because the other thing we said on the ventilator is the respiratory rate. So if I say that a patient has to breathe 20, what's going to be an easy divisible number, 30 times per minute, right? So that's one breath every 2 seconds. So if this patient takes longer than 2 seconds to fully expire that 400 cc's, the ventilator is going to stop them from breathing out, and it's going to push in another 400 cc's. So what we have then, so let's just say tidal volume inspired is 400, but the patient, for whatever reason, and we're going to go over a lot of those reasons below, can only expire 350 cc's of that tidal volume before another breath's prompted. Well, that means every single breath you're going to have a net positive 50 cc's of air left in the lungs. And if you're set at 30 breaths per minute, that means every single minute, 30 breaths times 50 cc's of trapped air, that's going to equal, oh boy, I'm going to show that I should go back and do more math in the classroom. I think that's about 1,500 cc's of trapped air in the lungs every minute. And you can picture if you're trapping that much air in the lungs every minute, you're going to increase the pressure in the lungs, right? And that pressure is essentially our intrinsic PEEP or our auto PEEP. Because what PEEP is, for those of you that don't know, it stands for positive end expiratory pressure. So it's the amount of pressure that the lungs are seeing when they're done expiring air. And we actually set this value on the ventilator typically, right? You'll say PEEP of 5, because that PEEP is what kind of keeps those airways open, right? And you want a little PEEP. But auto PEEP or intrinsic PEEP is PEEP that we did not set, that we don't want. It is PEEP that's added on to the PEEP you set on the ventilator. So let's say the intrinsic PEEP, is 15. The total pressure in the lungs then when the patient is done expiring is that intrinsic PEEP plus the PEEP you set. So it'd be 20, and that's a lot of pressure in the lungs. That's a lot of pressure they're seeing. So what causes this then? Why does this happen? Well, the thing that causes it is related to the physiology of the lungs. And it's kind of easy to think about if you break it down into a couple different things. So there's 3 things that affect a patient's ability to fully expire their tidal volume. One is essentially what we're doing with their ventilator. It's their minute ventilation. I wrote size. That's probably a confusing term. But you can just think minute ventilation, because what minute ventilation is the amount of volume they ventilate in a minute, which is going to be their tidal volume times their respiratory rate, right? And that's going to equal their minute ventilation. And we'll just write minute ventilation again just for the sake of ease. And this is something that we set on the ventilator, the tidal volume, and this is something we also set on the ventilator, the respiratory rate. So if we're setting these things really high, we sometimes can self-inflict auto PEEP. Again, because sometimes we're setting the respiratory rate really high because we're trying to get them to blow off all this ventilation to clear some CO2, and we can shoot ourselves in the foot a little bit if they start auto PEEPing. The other thing which is related, the other two things are related mostly to the patient's lungs. One is compliance of the respiratory system. So compliance is kind of like the elasticity of the lungs. Elasticity, that seems right, of the lungs. And it's going to, the mathematical equation, if you're interested, is change in volume over change in pressure. Not super important for the sake of this lecture. We're not going to dive into this concept in any amount of detail. But you can picture that if the lungs are more or less elastic, they're going to be able to push out that air either faster or slower, right? Because it's the change in volume over the change in pressure. So if your lungs are more elastic, you can kind of think of a balloon, they're going to push out that air at a certain pace compared to less elastic. And the time it takes for them to breathe that air out is going to affect their expiratory time. And if their expiratory time is too long, that's when you start to get breaths that are stacking on top of each other. The other thing, and the most common thing we probably think about with auto PEEP, is the resistance of the respiratory system. Because as we drew up here, we have kind of these small airways, these alveoli, right? And they're a small airway, and then it ends on this kind of air sac, this balloon, and this is an alveoli. And the air we breathe in flows down these small airways into the alveoli. It's oxygen. The oxygen diffuses into the bloodstream. CO2 from the bloodstream diffuses into the alveolus, and then that breathes out into those larger and larger airways and eventually out the mouth. But what we will see happen with patients with certain diseases is that they get some kind of collapse or obstruction or resistance of these smaller airways. And you can picture if these smaller airways kind of are collapsing down or spasming, or there's mucus or disease, when the ventilator pushes in a breath, it causes positive pressure, right? Because it's pushing air in to the system, and that'll stent open these smaller airways. Well, when the ventilator's done pushing a breath in, this pressure, and again, there's some minutia to this, but from an introductory topic kind of standpoint, this pressure is no longer there stenting those airways open, or it's much less. There is still, for those of you interested in more of the nitty-gritty, there's still PEEP, and the PEEP is what you set, right, that expiratory pressure, but otherwise, there's not air flowing in, right? It's trying to flow out, and sometimes what will happen is these smaller airways can collapse down, or sometimes they're just spasming, or sometimes there's mucus. And when that happens, there's more airway resistance. So that causes an increase in airway resistance. And that increase in airway resistance sometimes means it takes longer for that air to flow out of the lungs. And again, if the expiratory phase is longer, is prolonged, they're more at risk to stack those breaths again. So that's what causes it, and I'm realizing this is maybe confusing verbiage, and I think I was trying to be clever, but let me explain what I meant. So that's what causes it. What does it cause? AKA, what does the auto PEEP cause? Why do we care, right? That's always a question. Well, why do we care? Does it do anything? Does it do anything negative? Does it make a difference? Well, unfortunately, it does. It can cause a lot of really negative downstream effects, ranging from hypotension, so that's low blood pressure, right? And that's because if you're auto PEEPing, right, you have, we'll draw it again. So here's your windpipe, here's your bronchi, here's your lungs. But this is all stuck in this thoracic cavity, right? It's stuck in your chest. And this is kind of a closed system. So if you're auto PEEPing, we know that's increasing the pressure, right, in this system. Well, there's other things in this system too. You have a heart that sits right around here, and that heart has veins that dump blood into them, the superior vena cava and the inferior vena cava. And if the pressure in the system is really high, one could imagine that it's going to push on these veins and it's going to collapse them down, right? It's seeing all this pressure on both sides. And that can decrease venous return to the heart, decrease the amount of blood that can flow through these veins into the heart because that pressure is pushing on those veins, and that can cause hypotension, decrease cardiac output. The other thing that can happen is ventilator-induced lung injury. Again, if these lungs are seeing this huge amount of increased pressure, it can actually damage the lungs, damage those small alveoli, right? These are really thin membraned little air sacs. And if they're seeing all this increased pressure pushing out on them, that can cause inflammation, damage, fibrosis, and they can stop working. It also is really uncomfortable for the patient. So it can cause patient ventilator asynchrony or desynchrony. And you could picture, right, if that patient, every single time the vent's pushing a breath in, then they don't have time to push the air all the way out until the vent gives them another breath. And you can picture that over time, that becomes very uncomfortable for the patient. It can also cause a concept called trigger asynchrony or desynchrony. And I'll go over that when we go to those scalars up top at the end of the lecture. But it can cause the patient to have trouble triggering a breath. And then the other thing you'll always hear about is increased dead space. And this is a really important topic, but it's one I wanted to explain a little bit more. What does that mean? And to do that, I think, again, I'm going to have to draw a nice set of lungs here. So you have your windpipe, your trachea, into your main stem bronchi. And again, those branch off into smaller and smaller little areas, right? And at the end of these little areas is going to be the alveoli, which is much smaller than this because that looks to be the same size as the trachea, but it's much, much smaller than that. And that feeds into these lungs. So dead space is the amount of space in this whole system that is not exchanging gas, because the gas only occurs in the alveoli. So I'm going to erase this, and we'll say, if you were to magnify in a bunch, just kind of right here, what you would see is you'd have all these small, tiny alveoli, right? And the circles at the end are the alveolus where air is exchanged. And this is the only area gas is exchanged, right? Oxygen that's flowing in goes into the bloodstream. Carbon dioxide from the bloodstream goes into the alveolus and then flows out. There's no gas exchange in the bigger airways. It's all in the alveolus. So what you can imagine then is there's a amount of air in the system that's not exchanging gas, right? I'm going to make up numbers here. Let's say that the alveoli represent, this is truly just a completely made up number, 40% of this system. So let's say the alveoli equal 40% of the system. That means 60% of the system are all these airways that are not exchanging gas. And that is dead space, right? It's just the amount of air that's going to be sitting in these airways, because you take a breath in and that whole breath doesn't go to the alveolus, right? You're done breathing, it might get that far. And some of that air is in these small alveolus all throughout the lung, but some of the air is just sitting in the airways. And then you breathe carbon dioxide and you breathe it back out, right? And that carbon dioxide then travels, and some of it just sits in those airways and isn't breathed out the mouth. And that's called dead space. That's the amount of area in the lungs that's not exchanging gas. And increased dead space can lead to increased carbon dioxide levels, because you're not able to ventilate off, you're not able to breathe off that carbon dioxide because there's so much dead space. And when you auto PEEP, when you breath stack, that increased pressure can cause increased dead space because you're not breathing out all that volume, right? And each breath you might start to breathe out less and less volume. So if ventilation is your tidal volume times your respiratory rate, that is your minute ventilation, right? We went over that equation up here. And if your minute ventilation is partially related to your tidal volume, and as we said, your tidal volume, let's say it's 400, but you start breath stacking, so you only breathe out 350 cc's. That means there's 50 cc's here that are never part of the gas exchange equation. And as you breath stack, as you auto PEEP, as you get more and more intrinsic PEEP, this number might get less and less. You might start breathing in and out less and less air because that pressure is increasing. So now that pressure is so high that when the ventilator tries to breathe in 400 cc's, it can only get 300 in. But even with 300 in, there's so much air stuck in there. Now you're only pushing out 200, right? And your minute ventilation can go down and down and down. In addition to that, by hyperinflating all these areas, it can also increase that space. So you have less ventilation, and that can cause increased CO2 retention or hypercapnia. All right, so that's what it causes, right? All bad stuff. Hypotension from the increased intrathoracic pressure, ventilator-induced lung injury from those increased intrinsic PEEP pressures the lungs are seeing, patient ventilator asynchrony because it's so uncomfortable for that patient to be building up all that air in their lungs, and then increased dead space from decreased ability to fully ventilate. So how do we diagnose it and how do we manage it? Well, the way to diagnose it is actually over here. It's called, and we're going to go into the scalars after this, but it's called an expiratory hold maneuver. And what that means, if you can picture this, is let's actually maybe we'll go up to the scalar right now. We're just going to use the scalars one time, and then we're going to do more scalar work at the very end. So what an expiratory hold is, this is how you diagnose auto PEEP. So an expiratory hold. You guys might be familiar with an inspiratory hold. That's how you determine a plateau pressure, a topic for a different video. But the expiratory hold essentially is you have the patient, you make the vent hold at the end of expiration. So what you'll see is a patient gets a breath in, right, expires that breath out, and you say to hold it, and you'll see this line kind of flatten out here. That's the expiratory hold. And what it should be at the same place. When you do the hold, it should stay right here. It shouldn't go up because this is just the normal PEEP. But if you have auto PEEP, right, so this is the normal PEEP here, you did an expiratory hold. This is the auto PEEP or the intrinsic PEEP. It's the difference between the normal PEEP that you set and then the amount of pressure in the lungs at the end of expiration, because PEEP is positive end expiratory pressure. So when you do an expiratory hold, it should just be the PEEP you set. It should just be the positive end expiratory pressure. But if you have auto PEEP, that number on the expiratory hold will be higher than the PEEP you set, because that is the intrinsic PEEP, the auto PEEP, the breath stacking, the amount of new pressure in the lungs because of that retained volume of air that's building up over time. And that vent will kick out a number when you do this expiratory hold maneuver, and that's called the auto PEEP. So if we scroll back down, the one thing to note is this is very difficult if a patient is spontaneously breathing, right? Because let me erase that, spontaneously breathing. Because as we said, let's say hypothetically, you have a breath delivered, this is the pressure scalar, then you do an expiratory hold after the next breath, and it's starting to go up, but the patient doesn't like that, right? So they're going to breathe in, breathe out, and the scalar is going to get all weird, and you're not going to really get any real number. So if a patient's paralyzed, you certainly can do it. If they're deeply sedated and not working against the ventilator, you certainly can do it. But it's really difficult to do if a patient is spontaneously breathing. So then that begs the question, well, then how do you diagnose it? And that is where we're going to dive into our scalars a little bit more. So if you guys aren't familiar with scalars, I'd really encourage you to check out some of our other lectures. We have Introduction to Scalars, and then a handful of other videos involving different desynchrony. And we'll link those in the video description and the video comments because we don't want to belabor the points too much on what these scalars are. But just for a quick intro, this is the pressure scalar, right? Pressure as related to time. And this is all going to be, again, like we said, in volume control. This is the flow scalar as compared to time. And this is the volume scalar as compared to time. So what we see with auto PEEP if we can't do an expiratory hold, we can look to our scalars to gauge and get a little hints. So if we start with the volume curve, this is 0, right? That's 0 volume. And what you see in a normal breath is their volume goes up as they inspire, it goes down as they expire to 0, and then when the next breath comes, it goes up again, right? Makes sense. Let me get rid of those. In Auto PEEP, though, what you will see is they'll get their breath in, then they'll start to breathe out, but before they fully expire, that vent delivers them another breath in, right? And the same thing happens. So you don't go down to 0 the way you should, which makes sense, right? Because again, let's pretend the tidal volume is 400 cc's. You get 400 cc's that come in, but then only 350 cc's out before the next breath. If we're being thorough, the way these scalars tend to look, though, is that there's a really prolonged expiratory phase, right? So it goes up, and then the patient takes a long time to breathe out, right? And then you get another breath in, then they take a long time to breathe out. And that's related to different pathologies, which we'll get into more in a little bit. The flow scalar with Auto PEEP can also be a hint, right? Because the flow is, you get flow in, then you get flow out, and then it returns to 0, right? It returns to 0 flow before the next breath. Because there should be a slight kind of pause. There should be no flow, right? You get a breath in, breathe that out, pause, then another breath in. There should be a period where there's no flow in the circuit. Well, if you're auto peeping or breath stacking, again, it means you don't have enough time to expire. So you get flow in, and then again, there's this prolonged expiratory phase, and it usually doesn't come back down to 0 before there's a second breath, right? So same thing, look again, prolonged expiratory phase, doesn't hit 0, another breath in. And that can be a hint on the scalars that there's auto PEEP as well. Your flow is not returning to 0 with new breaths. And the pressure scalar is sometimes a little trickier. I think theoretically, you know, so pressure goes up when you're delivering a breath, comes back down, and as you auto PEEP, some would suggest that you should start to see this kind of marching up of the pressure scalar, right? Where this is kind of your auto PEEP that's building up over time, although it doesn't seem to usually demonstrate that on the pressure scalar. It's a little more complex than that. But those are some hints for how you can diagnose it on scalars. Really, the flow scalar and the volume scalar are going to be your two biggest hints. I had a patient the other day who quite literally their expiratory phase was so long it took up almost the entire screen. You know, the volume would go in, and then it'd be this super prolonged expiratory phase, and then they would breath stack. It was a really difficult vent to manage, but you will see that with certain disease states, as we'll talk about. So if we scroll back down, what are those disease states? And that's something important, right? Because treating reversible causes is a major way you can manage this. So things we see this in, COPD and asthma are the two big ones, right? Because these have bronchospasm, bronchorestriction, increased airway resistance is the name of the game in these. These patients have a really prolonged expiratory phase. In fact, just the diagnosis of COPD, prolonged expiratory phase is part of that diagnosis when they're not on a ventilator. You'll sit bedside and you'll have this inspiration and then this really long expiration. And you can see them with that prolonged expiratory phase. So that prolongation of the expiratory phase can really affect that. Also, patients with a lot of mucus can sometimes air trap as well. Treating the reversible causes, you're going to treat the underlying condition, right? COPD, asthma, steroids, nebulizer therapies to help with bronchoconstriction or bronchospasm. Sometimes magnesium is indicated. You know, all this is treatment for COPD asthma. Another thing to always make sure is that the ET tube is not kinked. The endotracheal tube is not kinked, because kinking the endotracheal tube can sometimes cause auto PEEP. If you picture the kink, right, we'll draw a tube here, and let's say there's like a little bit of a kink there. Well, when the breath gets pushed in, it can flatten out this kink, right? Because that's more positive pressure. And then when a patient is expiring, sometimes this kink will get even worse and they won't be able to expire outwards. So make sure that endotracheal tube is not kinked. That's an important one. In addition to that, sometimes we cause this ourselves, as we said, patients that we're trying to really increase their minute ventilation. Sorry, I realize I wrote minute ventilation up here for an easier shorthand. But yes, their minute ventilation, right? Because if we set the respiratory rate way high, we set the respiratory rate at 30, their tidal volume at 500, because we're really trying to get them to breathe a ton of air. They might have an acidosis. We're trying to help them breathe off. Well, as we said, respiratory rate of 30 means that they get one breath every 2 seconds, no matter what. We were telling the ventilator, we want you to give that breath no matter what. And their tidal volume of 500. So even if they don't have that prolonged of an expiratory phase, that can certainly mean patient breathes in, volume scalar is breathing out, and another breath comes in, right? Out. Another breath comes in, out. And that can cause them to auto PEEP because they just simply don't have enough time to breathe out that amount of tidal volume in 2 seconds. So sometimes this is a self-inflicted wound. So treating reversible causes is absolutely important. All right, increasing expiratory time. This makes sense, right? This is what you'd think. Well, if they need more time to expire, let's increase their expiratory time. How do we do that though? Well, a couple ways. It's important to remember that a cycle here is 60 seconds, right? So when we're talking about respiratory rate 30, it's 30 breaths in 60 seconds. So you kind of have some limitations here. One way to increase the amount of time they can expire is to simply decrease the respiratory rate, right? If you have this is going to be a volume scalar. If you have the respiratory rate set at 30, I'm just drawing a bunch, that doesn't give them that much time to expire. Whereas if you have the respiratory rate set at 10, they can take all the time they need to expire, right? Because there's not a ventilator that's going to be giving them another breath right away. The other thing you can do is adjust the inspiratory time. It's actually something you set, right? On a ventilator, there's an I to E time, inspiratory to expiratory time. Oftentimes this is set like 1 to 2 maybe. And that means that the amount of time they get to inspire is half the amount of time they get to expire. So let's just say this is 1 breath, right? This, if you look at kind of the amount of time, this is going to be once compared to 2. It's going to be half. So for the sake of ease, if you were to set the breath at let's say 9 seconds they had to take each breath, which is unrealistic. That would mean that this is 3 seconds of time to inspire and 6 seconds time to expire. Well, if you could change this, you totally could. This is, again, for the sake of the example, you would never make the I to E 1 to 9. But let's say you made it 1 to 9. That means in this example, instead of 3 seconds, they get 1 second to expire. And I guess my math is still not quite on, but 9 seconds to expire. So 1, and then they have much more time to expire. So you can decrease the inspiratory time and essentially prolong their I to E ratio, aka give them more time to expire with each breath. The other thing you could do is decrease their tidal volume, which makes sense. If they only have 1 to 2 seconds to expire and you're giving them, I'm just going to make up some ridiculous, you're making them breathe 800 cc's of air with each breath. Well, that means they're going to get these huge breaths that they're trying to expire out. And they might just simply not have enough time to expire out that huge breath. Whereas if you decrease the breath down to 400 cc's, for them, that might be enough time to inspire and expire fully. And you can decrease their tidal volume. Well, obviously, there's limitations to this depending on their physiology. But those would be the big things, right? Decrease respiratory rate. Decrease tidal volume. These are supposed to be arrows down for those keeping track of my scribbles. Decrease tidal volume. And you can prolong the I to E ratio, aka decrease the amount of time they're taking to inspire each breath and increase the amount of time they're expiring each breath. Okay, excellent. Other things to note. We're almost done, I promise. So there's this thing called trigger asynchrony, or difficulty with a patient prompting the trigger. The trigger is what the vent needs to see to have the vent understand the patient is trying to take a breath in and thus prompt the ventilator to give a breath. Because the ventilator's smart, right? If a patient breathes in, the vent is supposed to say, oh, okay, the patient's starting to breathe in. I'm going to deliver a breath with the settings you gave me, tidal volume, right? PEEP, I to E time, but the patient prompted this breath. They triggered this breath. Well, the way the ventilator often detects that is by detecting a change in pressure. And that change in pressure has to be this net change. And this is I'm going to put out a separate video on this topic in general. So if this is confusing, I promise we'll make it more clear in another video because it requires more time. But what this means is if you set the PEEP higher, so let's say you have an auto PEEP, you're auto PEEPing, your breath stacking, and that auto PEEP is 20. It's a high auto PEEP. That patient will have a lot of trouble triggering a breath because they're trying to breathe in against all that stacked intrinsic PEEP, all that stacked air, and they have trouble mobilizing enough negative pressure to overcome that. But if you were to increase the PEEP they were set at, right, because this is their intrinsic PEEP. So if you were to say, all right, well, I'm going to set the PEEP at 14, just the normal PEEP, that is going to allow that patient to mobilize a breath a lot easier because there's already all this PEEP set to help them overcome the auto PEEP. Again, I probably shouldn't even included it in here, but for sake of thoroughness, I did. But stay tuned for another video on that. And if worse comes to worse, let's say a patient's now hypotensive. They're not able to get in enough air. Their breath stacking so terrible. They're kind of on the cusp of coding. Disconnect them from the ventilator. Literally just take the endotracheal tube off the ventilator, and that patient, you can push on their chest even, they'll just breathe out all this air that's been breath stacked over time, and you'll immediately see their blood pressure get better. You'll see their plateau pressures getting better. Because it's another thing I probably should mention as diagnostic maneuvers. Auto PEEP increases plateau pressure. All right, so plateau pressure, for those of you that don't know, is the inspiratory pressure. So if you push a breath in, make the patient hold it, the ventilator then just detects the amount of pressure there. And you can guess that that auto PEEP would increase the inspiratory pressure, right? Because you have all this pressure built up in the lungs that if you push another breath in and then pause, you don't let any volume leave the lungs. It's an inspiratory hold. The auto PEEP will be all that air that was already in the lung, in addition to the air you pushed in the lung during the inspiratory hold. So that's going to increase the plateau pressure. So when you disconnect a patient from the ventilator, push on their chest, let them breathe all that auto PEEP, all that stacked breath out, hook them back onto the ventilator. You'll see that plateau pressure go back to normal, their blood pressure get better, and all that good stuff. All right, so this was our lecture on auto PEEP or intrinsic PEEP or breath stacking or air trapping. I hope it was helpful. I hope you enjoyed it. Definitely check out some of those other videos. Let us know what thoughts, comments, questions you have down below. We definitely appreciate you all. Stay well, keep learning. We'll see you next time.